Hello and welcome everyone again. In this presentation, I'll be talking about ADHD really in a nutshell, and I'll be just talking about briefly about the diagnosis. And let's start. The core symptoms, as we know, it's a triad of hyperactivity, inattention, and impulsivity. And what it really means that these symptoms are kind of showing the surface when a child going to the outwards into the schools, and there were some concerns shared by the teachers. And the first one of these three core symptoms is that inattention, and we kind of find the child distractible and really cannot sustain any attention to tasks at the classes, and really doesn't respond, and kind of staring away when spoken to directly, and fails really to complete tasks. And this is in comparison with his peers. And the child usually found to be disorganized in the way he handle tasks and avoid tasks that require sustained mental effort. So these all fall into the inattention, and also the child will be forgetful and really doesn't remember what items he needs to have for certain planned activities or tasks. The second core symptom is hyperactivity. So a child would be hyperactive, fidgets, and really can't stand still in the seat, and sometimes leave the seat, and when he is instructed beforehand to stay in, so he can't really remain still, and cannot play quietly, and usually talks excessively and out of proportion of the volume and of talk in comparison with his peers. And he tend to have impulsivity, which is really he got some difficulty awaiting turns when in a row, and interrupt and intrude with others. And he tend to have impulsive actions, and sometimes it's dangerous actions, and himself and towards the other. So when this type of patients come into office, the first line of treatment is usually non-pharmacological. It's just behavioral therapy and training for the parents and teacher, and really getting the school counselor or the school teacher as well as the parents looped in the same supportive approach. The medications usually for the children is methylphenidate and dextroamphetamine. However, dextroamphetamine is a little bit expensive, so methylphenidate 10 to 20 milligram per day, and the initiation for this will be 5 milligrams twice daily, and then for 2 days, and then we'll educate the parents about the side effects, and which we will be talking about in a bit. And then we will increase the dose to 10 milligram twice daily. And there are two forms for the methylphenidate: the short or immediate release, abbreviated with SR, or long acting, which is a CR methylphenidate. Well, which, if you'd ask which one we use in the initiation phase, it will be the long-acting methylphenidate usually. And the reason that it's considered the first line is because of better compliance overall, and it has less rebound hyperactivity as a side effect, and it has good administration time and timing, especially if the kid will be in the school, and it has less abuse potential. So all this makes the long acting much favorable. And the side effects you monitor is usually insomnia and difficulty sleeping, anorexia, and weight loss, as well as abdominal pain and headache. So we have to screen for all these side effects and educate the parents about them during the initiation. And the stimulants is usually not for patients who's less than 6 years and which it's better to have a non-pharmacological effect, and the effect is in 1 week. So monitor for effect in improving in the core symptoms in the first week of initiation, and the total expected effect will happen on the over 4 weeks. So we have to reassess in the 4 weeks, and if everything is going well, we have to continue for 12 months and then reassess every year. So there are certain things to monitor in the fourth week and after 12 months. And just a heads up about any smoking potentiality or abuse of methylphenidate in the future. The literature advised to use atomoxetine or guanfacine for less abusive tendency and less issue with smoking habit. Monitoring, we usually monitor the patients for sleep and appetite, and for children we should do height and weight at every visit, and the number we're looking for is 10% or more declining in the growth of height or weight. That's a concerning sign that we have to reassess the medication. We have to monitor blood pressure and heart rate as well. And the next thing is the pregnancy and lactation. So non-pharmacological approach is the first line when we diagnose ADHD, and it's really not very uncommon to find it in pregnant ladies. So if the diagnosis, the core symptoms fits, the amphetamine is okay for pregnancy, it's acceptable. However, after pregnancy and delivery, it transfers to milk and requires monitoring for the newborn baby. For insomnia, basically irritability and poor weight gain of the baby. And the other medication that we can use for the pregnant lady is methylphenidate, and however we have to counsel the pregnant patient about the cardiac malformations and the fetus. However, it has less secretion with milk. And that concludes our presentation about ADHD. Thank you for watching, and see you again in another presentation.